Welcome to Wisdom Radio. I'm Dr. Rusty Hoffman, Professor of Interventional Radiology at Stanford, bringing you a direct line to critical research and interventional updates. Powered by AI, curated by experts. Let's get started.
Today, we're tackling one of the most frustrating, resource-intensive clinical problems, the recurrent occult GI bleed.
They've burned through multiple negative endoscopies. The CT angio was equivocal.
Maybe they had a confusing tagged RBC scan a week ago.
Exactly, and they're just cycling through daily transfusions. Sometimes they're critically ill. And we, as IR practitioners, we get called in when all the standard methods have failed. And that's when we reach for, well, the ultimate diagnostic maneuver.
And that ultimate maneuver is the focus of our deep dive today, Provocative Mesenteric Angiography, or PMA. It's defined by the intentional transcatheter provocation of rebleeding.
We are essentially trying to make the patient bleed, but on our terms, so we can actually see the extravasation on angiography and then, fix it right then and there.
Yeah. How do we do that? What are the agents?
Well, we achieve this by injecting intra-arterial tissue plasminogen activator, TPA, along with a strong vasodilator like nitroglycerin.
Yeah.
You put it directly into the mesenteric circulation. The whole point is to just momentarily tip the scales, dissolve that tiny clot that's hiding the source, and then treat it, usually with embolization.
Or sometimes guiding a surgeon, I imagine.
Or guiding a surgeon, yes.
The source material we've pulled together for you today is a bit of a game changer. It's the single largest cohort analysis to date of this specific TPA-based technique. It's a massive 22-year retrospective study. We're talking 119 procedures on 109 patients.
And the mission is clear. First, confirm the safety of using TPA. Second, give us an updated measure of how well it actually works. And third, and maybe most importantly, identify the specific predictors that, separate a successful procedure from what can be a low-yield time sink.
All right, let's start with the big one, safety.
Yes, let's. Because that's where any good IR practitioner starts when you're considering a high-risk procedure. You tell a referring clinician, you're going to inject a thrombolytic, a potent one like TPA, into a patient who's already bleeding and, well, eyebrows go up.
Understandably so.
But the headline safety data from this 22-year cohort should reassure everyone. 0 major bleeding adverse events were observed.
Wait, 0?
0.
That's remarkable considering the clinical scenario and the drug we're talking about.
It is. And critically, there were no cases of uncontrollable GI bleeding because of the provocation. The only adverse events they documented were 3 self-limited access site hematomas. Minor stuff. Didn't need any intervention.
So this safety profile, that's really the most compelling argument for keeping this in our toolkit.
It absolutely is.
Yeah.
Especially for the really sick patients.
Okay, but why? Why is it so safe in this specific territory? If we gave that much TPA systemically, we'd be in a lot of trouble.
Right, and it comes down to some really favorable pharmacokinetics. It's a key scientific takeaway here. When we infuse TPA and nitroglycerin into the mesenteric arteries, the SMA or IMA, the agents are routed directly to the liver through the portal vein.
Now, the liver acts as a filter.
TPA and nitroglycerin are highly susceptible to what we call first-pass hepatic metabolism. They're just cleared out so rapidly that they never reach the systemic circulation in any, clinically significant quantity.
So the anatomy protects the patient. That lands clearly. Okay, let's pivot to the yield. Safety's great, but did it actually solve the problem?
A fair question. So PMA successfully induced active extravasation in 27.7% of the procedures. So 33 out of 119.
27.7. That's a modest number.
It is a modest positivity rate, and we have to be honest about that. It means most procedures were negative. But, and this is the crucial clinical translation, when the bleed was successfully provoked, the subsequent management was overwhelmingly successful. All 33 of those positive cases received definitive therapy. 32 were treated with embolization, and 1 patient went for surgical resection.
So the takeaway is if you can get it to bleed on the table, you have a really high probability of stopping that bleed for good.
Precisely. And look at the clinical success rate for those positive cases. No rebleeding from that site within 30 days was achieved in 70% of those patients. The issue isn't treating it. The issue is finding it.
Right. And we do need to put that 27.7% in context, though. I mean, it sounds a little low, but the paper reminds us of the history here.
It does. Historically, you had studies using older agents like urokinase or streptokinase, and they reported much higher yields. Some as high as, 84.6%?
Wow.
But, and it's a big but, those agents are generally not available anymore, and more importantly, they were associated with real systemic bleeding complications, real morbidity. So the modern yield of 27.7% using the much, much safer TPA is probably an acceptable trade-off for less major adverse events.
It just underscores that we need to be smart about who we select for this.
Exactly.
Okay, so that brings us to the next segment. And this is, I think, where the study really earns its spot on every IR reading list. If we accept that 27.7% yield as the cost of safety, we need to know how to move our personal success rate up by, excluding the low-yield patients. Let's unpack that multivariable analysis. What truly separates the successful procedures?
This is the study's most significant contribution, I think. It distills the whole decision-making process into just two independent, highly significant predictors. It tells us we need to focus less on some of the peripheral data and just zero in on these two markers.
Okay, lay them out for us, and what do they imply about the bleed itself?
Right. Number one, stool character. Patients presenting with hematochezia had significantly higher odds of a positive PMA. The odds ratio was 6.756.
So almost 7 times more likely to get a positive study if the patient has hematochezia versus, say, melanoma, which makes profound clinical sense, right? Hematochezia implies a more rapid transit, a lower GI source.
Right.
It suggests a higher flow, maybe a less coagulated arterial bleed.
You've got it. That's the thinking. The second predictor was having a prior positive radiologic study. So if the patient at any point during their admissions had a positive CT angio or a positive tagged RBC scan, even if the bleeding had stopped by the time we got to them, that was strongly predictive.
And the odds ratio there.
Almost identical, 6.774. Again, almost 7 times more likely to succeed.
I'm curious, though. Many of these patients are massive bleeders. They're consuming units of blood. Why didn't something seemingly obvious, like, say, getting 2 or more units of packed red cells, why didn't that hold up as an independent predictor?
That's a critical question. And factors that suggest massive acute bleeding, like an acute GI bleed admission or needing those transfusions, they were significant on the univariable analysis. They definitely suggest a sicker patient. But when the authors ran the complex multivariable model, strip out all the codependencies, only the stool character, the hematochezia, and that prior imaging history remain as truly independent, non-redundant predictors.
So that tells us the nature and the history of the bleed are better indicators than just the acuteness of the anemia right now.
Yes, that's a really important nuance for the clinician doing the consult.
Okay, let's talk about the negative predictive findings.
This is it. This is the powerful takeaway for optimizing your workflow and avoiding a futile procedure. 0 patients, 0 out of 11 who presented with melanoma and had negative prior radiologic studies had a positive PMA.
0.
If you have a patient with black, tarry stool, and every tagged RBC scan and CTA has been negative, PMA is highly unlikely to be worthwhile. Not based on this large data set anyway.
That 0 out of 11 cohort is just such a signal to shift to other management strategies.
It really is.
Let's shift now from selecting the right patient to executing the procedure in the best way possible. So if we have a well-selected patient, the one with hematochezia, maybe that positive CTA from 3 days ago, what technical adjustments move the needle on that overall success rate?
The primary technical differentiator was achieving maximum vessel selectivity. And this speaks directly to how we use our tools in the lab. Procedures where the catheter was advanced more distally were just significantly more successful.
So we're talking about using a microcatheter system, really getting down into the smaller vessels, chasing the suspected source.
Exactly. Procedures that reached a third order or a super selective level of administration had a 63.6% positivity rate.
63.6, okay.
Now, compare that to procedures where the drug was just administered into a first-order visceral vessel, say, just the proximal SMA. The yield there was only 21.5%.
Wow, that is a massive difference.
And that selective delivery, in turn, it directly informed the next key finding, the importance of concentration. We're realizing it's not simply the total amount of drug you infuse, but it's the density of the TPA at the suspected bleed site that really matters. The study spanned 2 decades, so the absolute doses of TPA varied a lot. So the authors calculated an estimated concentration ratio, and that ratio is a much better predictor than the total dose.
Can you walk us through the numbers on that for nitroglycerin?
For sure. For nitroglycerin, the positive studies had a median estimated concentration ratio of 20 versus only 5 in the negative studies. The cumulative dose was also higher in the positive cases, 250 mics versus 200. The implication is pretty clear. You need high local concentration to get that vasodilation you need.
And what about the TPA dosing? The numbers here seem a little counterintuitive. The median total dose was actually lower in positive studies. 6 milligrams versus 11. Why is that?
That's just procedural flow. The dose was lower in the positive cases because the operator stopped the infusion the second they saw extravasation.
Of course. You found it, you stop.
Exactly. The negative studies continued the dose escalation. They kept chasing the bleed, sometimes up to the institutional max.
Which suggests their institutional practice for TPA dosing probably needed an update based on their own experience, right?
It did. And they note that. Based on their evolving experience and recognizing this trend toward concentration and rapid escalation, their current practice is shifting. They're starting with a higher routine dose, around 10 milligrams, with a rapid escalation to 20, but always pushing that delivery as selectively as possible.
And just to confirm, what were the primary patient-level exclusions that were consistently honored?
The main contraindications were known portal hypertension with varices. That's a totally different beast. And recent GI anastomosis, defined as within the prior 3 months. Just concerns about disrupting a fresh surgical site, those patients were generally avoided.
Okay, good to know.
So to summarize for our IR colleagues, PMA remains a really important, safe, albeit modestly successful tool. It's for that subset of patients with recurrent, massive occult GI bleeds who are, just running out of options. The confirmation of that excellent safety profile, thanks to first-pass hepatic metabolism, is maybe the most significant finding here. 0 major hemorrhagic complications. That really lowers the bar.
But given that overall 27.7% yield, patient selection is paramount. You have to target the patients with hematochezia and ideally those with a history of a prior positive scan. And that specific low-yield cohort, the melena and negative prior imaging group, that should probably be a clinical exclusion for this technique.
And we also touched on emerging competition. The discussion notes that carbon dioxide, or CO2, angiography is showing some highly promising preliminary results. Reported success rates from 48 up to 79%. CO2 is quickly reabsorbed. It has a fantastic safety profile. It could become a preferred alternative one day, but it needs more data. For now, PMA is the most validated, safe, and effective pharmacologic agent we have when you use it correctly.
And finally, a provocative thought for you to consider. Given how dramatically the odds of success jumped when the TPA was infused selectively, increase up to 63.6% positivity, how should we prioritize advanced diagnostic localization, like a highly selective CT angiography, purely to guide our microcatheter position for a later PMA? It kind of changes the calculus of what a successful initial workup is if that workup, even if the bleed is stopped, directly informs the high-yield territory for your next and final interventional move.
So as a bonus, we have Dr. Charles Kim from Duke, the chief of interventional radiology there and senior author on this paper, providing a few minutes of commentary. Grateful to Charles for providing this context to our listeners.
So I thought this was a really great discussion that captures the major points as well as the nuance that our team wanted to convey in this paper. As you can tell, we have been performing provocative mesenteric angiography for several decades now and have collectively put a lot of thought and discussion into it. In terms of future directions, I'm not really sure if we'll learn much more from a larger sample size or additional and retrospective analysis of provocative angiography with TPA, and I don't really see a need for randomized studies. I think of it more as a last-ditch procedure that is worth trying for these desperate patients in need. So I do think IRs at major hospitals should be comfortable with performing this procedure. However, I'm really interested in learning more about CO2 provocative angiography. The few studies in the literature have a really high positivity rate, which I haven't quite been able to replicate, but for all I know, I'm doing it totally wrong or in the wrong patients. But in any case, CO2 is probably about as safe as you can get and won't stress out referrers who worry about hemorrhagic complications with TPA, especially since TPA is officially contraindicated in patients with recent GI bleeding. And I know that some IRs at some hospitals face opposition to this procedure for those reasons. Regarding CO2 angiography, we have been in fact using it as part of our sequence prior to performing provocative angiography with TPA, but so far we haven't really improved our understanding or yield of successful procedures. So I'm looking forward to seeing what else the CO2 experts learn and report about CO2 provocative angiography.
This is Dr. Rusty Hoffman, and that's a wrap for Wisdom Radio. Download the Wisdom app by searching for Medical Wisdom, spelled WYSDOM, or visit medicalwisdom.ai for rapid-fire videos, podcasts, and community insights. And remember, knowledge is the best medicine.